stand to present myself and to formally kickstart proceedings. So hello and thank you all for coming out. There was always a jam-packed options to choose from with Fringe events, so really appreciate folk coming along to this one for a really important topic as we start to look at reversing the trend and addressing health inequalities in Scotland. So I'm Philip Whyte, I'm the director of IPPR Scotland. So we are a progressive think tank based across the UK but with dedicated functions and office within Scotland. We're cross-party, as I say, progressive, and importantly we're neutral in the question of independence, but not on the future of Scotland. This is a really important event today. I think health inequality is an issue that has dominated Scottish political debates, since even before devolution. Scotland's a country that has faced very specific issues when it comes to health inequalities, both in the social determinants that give rise to health inequalities and then the impacts of those, what those look like. And again, not just across Scotland, but we also know that in particular, really specifically geographically located in some instances as well. So it's a huge issue. It's one that absolutely I think that we will come on to across the rest of this afternoon. As much as an issue of health inequalities, actually so often it's not an issue of health policy. Instead, it's about, again, those wider social determinants, right from a child is born. And again, the kind of life opportunities that they have and what that means in terms of social services, public services. So a really important event, and I hope we will have a really good discussion. I'm really delighted that we have got a fantastic panel. So I will start to my right. Very delighted to have Bibby, who is Director of Health at the Health Foundation. So she leads the Health Foundation's Healthy Lives strategies to create opportunities for everyone to lead a healthy life. And most importantly, we're absolutely delighted to have the support of the Health Foundation to be able to run this event this afternoon. Next to Jo is Creegan. So Creegan is the chair of the expert advisory group for an independent review of health inequalities the Health Foundation is currently running in Scotland and has a huge range of experience kind of across health and wider public services in Scotland. And then last but by no means least, absolutely delighted to be joined by Constance MSP, the Drugs Minister. Angela's had a variety of posts in a good way, since being elected to the Scottish Parliament. And again, I think really importantly, some of those posts, and again, those wider issues that we know go on to determine a person's life opportunities, life chances, and again, the interaction with health inequalities, not least around education, training, and skills, and then also brings experience prior to her election in social services. But most importantly, since 2010, she has been Scotland's first ever Minister, specifically for drugs policy. And again, we know that the issue of drugs is one that bears really heavily on health inequalities, but again, much like the wider issue of health inequalities, is an issue that is quite often born from, again, those wider social determinants. So again, it's impossible to kind of separate the two out. So really delighted that Angela's here to not just talk to that issue specifically, but again, to address those kind of wider issues. So everyone will kind of give their opening remarks. I will then facilitate a little bit of discussion between all the speakers, and then we will throw open to the floor. I'm delighted to hear kind of your questions and comments on this really important issue. So no further ado, I will hand over to Angela. Thank you.
Thank you very much, Philip, and can I say I very much appreciate the opportunity to be here along with the IPPR and the Health Foundation. As Philip has outlined, today's Fringe meeting is entitled Reversing the Trends and Addressing the Health Inequality Crisis, and I'll come back to that word, crisis. But the starting point for me is always to truly understand the scale of the challenge that we face in Scotland. And while much of what we are currently wrestling with is not unique to Scotland, some of it is. We know that COVID hit the poorest the hardest. We know the relationship between health inequalities and poverty is very explicit. We know there's a widening gap in life expectancy in terms of 24 years healthy living less for the poorest men. We have the worst drugs death rate in the whole of Europe and amongst the worst in the world. And although the latest figures showed that last year, for the first time in 7 years, we didn't have an increase in drugs death, the reality is the scale of the loss of life remains too high, and we still have amount to climb in this country. And of course, it's not just drug deaths, we also are losing over 1,000 people a year to alcohol, over 1,000 people a year to suicide as well. So I do think it's important that we call a spade a shovel, and these are tragic, avoidable and unacceptable deaths, and we should all be angry about deaths caused by, irrespective of the health equality, because these are preventable deaths, and that's what we should hang on to each and every day. And I know that right now it feels as if we are living in perpetual crisis. You know, when I look back in my time in Parliament, 15 years, and you know, so we had the 2008 financial crash, we've had austerity and so-called welfare reform since 2010, we've had the Brexit Bureau, we've had a global pandemic in terms of COVID, and we now have, you know, a cost of living crisis, and of course, in my humble opinion, we've got the Tories doing everything they can to trash the economy. And in amongst all that, you know, we have a drugs death crisis and a life expectancy crisis as well. And one of the questions in here in today's discussion is to what extent have we secured a public health approach to a public health emergency? And the pandemic itself demonstrated the importance of those big, bold economic and fiscal levers of power that, you know, rest not exclusively but in part with the Chancellor of the Exchequer. And I only need to point to things such as the furlough scheme. But what does a public health emergency, what does that mean in a Scottish context, in a devolved context? So if I can just use the example of drugs policy, I do think this, you know, applies to other areas of policy as well. So in terms of what does that public health emergency mean? Well, first and foremost, it's about poking, it's about prodding, it's about challenging the system as a whole and every tier of government to say that there is still a public health emergency for some of our most marginalised, excluded and stigmatised citizens in our country, and that is not good enough. There is that very core emergency response about what do we need to do to keep people alive? What do we need to do to prevent people dying from a drugs overdose? And many of you will be familiar with our work around increasing the distribution of naloxone, an emergency temporary medication that essentially buys time to allow emergency services to attend. There is other work in terms of what do we do when people survive a near fatal overdose? Well, they really need that 5-star treatment, because that is a moment, it is a golden moment of opportunity that people often have when they're in crisis, and that really means we need to get people into treatment or recovery quicker, because we know, and that's the second strand of any public health emergency, is treatment, support and recovery, because it's protective, and we know that, and there's a whole, you know, there's decades of evidence. And this isn't about a fight between abstinence-based recovery or harm reduction. Actually, it's every part of the jigsaw. The scale of the challenge, in particular in relation to drugs, is so big, we need all the parts of the jigsaw. And I'm not interested in arguments about whether we're supporting resi rehab over harm reduction, safe drug consumption rooms, or vice versa. I am only interested in supporting people, and that means reaching people wherever they are in their journey. And the third thing is about, you know, that right to treatment and recovery, that protective treatment and recovery. And then latterly, it's, you know, the fourth strand to all this is we have a national mission for a reason, whether it's in terms of drug deaths, whether it's in terms of child poverty. Because this isn't, we are in the business of saving lives, but we're also in the business of trying to improve lives. We don't just want folk to survive, we want them to survive. So, you know, absolutely reach their full potential and lead the lives that people aspire to, and lead the lives that they are entitled to aspire to and entitled to achieve. So for drugs policy, that means we can't have drugs policy in isolation. It needs to be joined at the hip with reform in the criminal justice service. It needs to be joined at the hip with primary care. It needs to be joined at the hip with mental health. It needs to be joined at the hip with prevention, early years, our work in adverse childhood trauma. What are we doing? That work in terms of being a trauma-informed nation and addressing, the ACEs, 1 to 10. And it needs to be that all Scotland, all government response. And I suppose in short, in terms of any public health emergency, it needs to be both a sprint and a marathon. And I know I've been around government long enough to know that strategies are important, but they will only take you so far, and that it's all in the implementation. And I suppose this is where I get to the stuff that's perhaps not that politically sexy, but it's the stuff that we need to be absolutely under the bonnet on, and that's about culture, that's about tackling stigma, that's about leadership at all levels of government, it's about accountability at every level of government, it's about innovation as well as investment. This isn't just about statutory services, this is also about the crucial role that the third sector play, and it's also about models of care. And if you look at the Scottish Government's Heart Disease Action Plan, there is a recognition that some of our communities are underserved by current models of care. Now we know there is some good experience, good practice. I'm very proud of the work that we did in building social security in Scotland, not just because I was involved in it, but having that experience panel of 2,000 folk with real life experience that helped build that organisation from the ground up, I would contend has made a difference. I think the reforms in the youth justice system, which has seen an 85% drop in children between 12 and 17 being proceeded against, the fact that we met our youth unemployment targets 4 years early back in 2017, I think demonstrates the power of vocational education and developing Scotland's young workforce. But there's a journey that we have still yet to complete, whether that's around no wrong door in terms of connecting mental health services and substance use services, keeping the promise to our care experienced young people. As I said, primary care is important to me because, as well as the co-current relationship between mental health and substance use, the physical health of people who use drugs is very poor. And we need to pay real close attention to that. And there's also the work that we're doing in the National Care Service, the biggest reform since the establishment of the NHS. But of course the permanent undercurrent of all of this is of course poverty. And you may have read recently that the Glasgow Centre of Population Health, actually quoting the UN, said that wealthy countries all around the world, in wealthy countries all around the world, including the UK, poverty is a political choice. So what could be done? So if, for example, the so-called welfare reforms were reversed, and by that I mean the 2-child limit, aka the rape clause, if the £20 universal credit uplift was reinstated, if the benefit freeze from 250 to 20 it was truly compensated for, we would actually put £780 million back into the pockets of the poorest households in Scotland. And that would lift 70,000 people in this country out of poverty, including 30,000 children. But that is not a road that has been chosen. So by contrast, the Scottish Child Payment will see an investment in excess of £600 million over the next 2 years. That Scottish Child Payment started off at £10, it went up to 20, and it's been raised to 25. 5 times greater than what was asked for in terms of the Give Me 5 campaign. And part of the child poverty plan, when it's delivered, is that it will reduce child poverty to the lowest levels for 30 years and lift 60,000 children out of poverty. So that's what we can do with 15% of welfare spend. It therefore begs the question what you could do with a bigger deck of cards, so to speak. And of course there is what we're wrestling with now, given the cost of living crisis and everything that's happened south of the board, is that limit. There is a limit to what you can do in terms of mitigation, because for every pound spent on picking up the pieces is a pound less you're spending in actually lifting people. You're spending money to sometimes keep people where they are, to stop their situation getting worse, instead of investing resources to actually lift people out of poverty. So Philip, I promised I would be characteristically brief, and I'll just end on the note that, so this debate is about what we could do in the future, as well as what we could do now, what we could do with that whole pack of cards, as well as dealing with the deck that we've been dealt with. And there's also a bit about courage, courage to be open to challenge as a government, the courage to lead by example. I spend much of my time challenging others, but I have to be open to that challenge and scrutiny too. And there's a courage about conversations that we need to have about things like reducing the prison population, managed alcohol projects, safer drug consumption facilities, heroin-assisted treatment. And it's that courage to be able to meaningfully engage with communities who are impacted the worst, whether that's by drugs or other health inequalities, about what the evidence tells us. What does the evidence tell us about what will work? And evidence isn't just, and no disrespect to academics and the great minds, evidence is also about that lived experience. And ultimately, for me, evidence is about taking responsibility for the powers that we don't have, but also, taking responsibility for the powers that we do have. And we have a duty to deal with and use our powers that we currently have expeditiously and to maximum effect, to stretch them as much as possible. But we do need to be, constantly demonstrating that broader conversation about what we could be doing with the powers that we don't have. So thank you very much.
And thank you, Angela. Next I'll turn to my right and ask Julie to give a few words.
Thank you. I think I won't stand up. That's okay, partly because I probably won't be able to read my notes if I'm standing up. So anyway, thank you for hosting this event. Those of you that don't know us, the Health Foundation is an independent charity, an endowed charity, and our mission is to improve health and care for people across the UK. The way we do that is we fund research, we fund improvement work, we work with policymakers to provide evidence, and we also engage the public in understanding what they see as priorities. And we've had a long history working with Scotland, particularly with the NHS in Scotland, on improving patient safety and person-centred care. But the work we're doing at the moment is a review of health inequalities in Scotland. So kind of why are we doing this? What value can we add? As we've heard, I think we know it's long established that there's very wide health inequalities across the UK, and in Scotland there are some marked differences from other parts of the UK, as we've been hearing about. But what we're trying to do with the review is bring a kind of more holistic view, sort of lens to this problem. And we're doing this by pulling together evidence from a series of different inputs. We've commissioned 4 areas of work. The first is to look at public health trends, so trends in ill health, in death, in risk factors that cause ill health, and that's been done for us by the University of Glasgow, and they will be producing a report to publish shortly. The second report we're putting together is from the Fraser and Allender Institute, which is going to be looking at the wider trends in economic factors, social factors such as education, employment, transport, effects of rurality and urban factors and so on. So looking much more broadly at the causes of health, good health or poor health. The third area we've done is working with Nesta Scotland to really try and understand what the sort of stakeholder community feel about the current policy and direction of travel around health inequality, and to bring that perspective from across the third sector, people working with government and other stakeholders. And then finally, the fourth element that we're bringing together is what is the public view and the public experience of health inequality. So we're working with the Diffley Partnership, having carried out some deliberative work and national survey work to really understand what do the public in Scotland currently know and understand about what's causing health inequalities in Scotland. And then through the deliberative work, taking them through a journey of understanding and building and explaining evidence, and then finding from them what would they actually want to see government prioritising, and what do they think would make the most difference from where they're sitting. So we're going to have these 4 reports coming out over the next few weeks. And then the Health Foundation, working with an advisory group, which Chris, who you're going to hear from in a minute, chairs, we will be trying to pull together an overview report to be published in January. And what we're not going to do is provide a list of recommendations, because we know, it's like the world is replete with recommendations. But what we want to try and highlight are some of the areas where we think there's an opportunity to perhaps approach things differently, think a little differently, and maybe sort of try and create or pull some levers that kind of maybe aren't being utilised to the full at the moment. So one of the things is, how do we engage the public much more in this debate? The work we've done in the UK, whether it's across the UK, we find that the public do not actually generally know the extent of health inequalities that exist, whether it's in England, Scotland, Wales, Northern Ireland. And when they hear the extent of inequalities, they genuinely are shocked. And what people often think is, they think, well, it's about the NHS, it's like, we just need better NHS. But we know that's not the case. We know it's all about sort of the start in life, the jobs people have, where they live. And as you take the public through this process, they understand that it speaks to their real lives. They know that. And we can see that we're starting to build much more support and backing for some of these wider strategies. So we think there's some opportunities working with the public. We think that there's opportunities looking beyond government and the role of business and employers, and what can they be doing. And we also think that there's something around this implementation challenge. So we're going to be looking at some of these themes where we think there's opportunities to maybe focus attention and hopefully have more impact. And the Health Foundation, this is something we want to be in for the long haul. We want to look for opportunities to follow up on the findings from the report. We want to hear from people who want to engage with us in taking some of these ideas forward. So it's great to have an opportunity to talk to people here today. Hope this is the start of the conversation, and I'll finish there.
Thank you very much. Looking forward to it. And last but not least, I'd like to introduce Chris Creegan.
Thank you. Inevitably, when you go last, some of the things you were going to say have been said. As Philip and Joe have said, I agreed to chair the expert advisory group for the review that the Health Foundation have funded and commissioning. And I suppose a question for me at the start of all of that was, as somebody who's been around a kind of policy lens on a number of things for quite a long time, is what can a review of health and health inequalities tell us that we don't know already? Don't we already have all the data we need? Don't we already know what we need to do? And shouldn't we just get on and do it? And I think those are all kind of valid, perfectly valid questions, and they're all questions I asked myself when I originally spoke to Joe about whether or not I would get involved in the work. Joe's talked about the Health Foundation's approach, and it was that approach that certainly for me was attractive, because on one level the answer to all those questions is simple. The unfair gap in health outcomes is, and Angela, you've said it's one of the biggest challenges we face. So an opportunity to be involved in trying to fix that in some way is interesting. And in my work in Scotland over the last couple of decades, I've been involved in a kind of executive, non-executive capacity across organisations and institutions dealing with looked after children, people with learning disabilities, people with mental health problems, social security. All of those things have significant footprints in the health inequalities landscape. So, and I don't refer to any of that to simply sort of demonstrate my credentials or even my interest, but rather because I think, as has been illustrated by both what Angela and Joe have said, it serves to illustrate both the starkness but also the complexity of the problem. There isn't one lever here, there are many. As Joe said, the first of, we're going to be publishing a series of reports over the course of the next month or so, really. And the first of those reports, which is about to be published, focuses on public health trends in Scotland since devolution. And we've gone all the way back to 2000. There's a kind of a sense of how's Scotland doing 20 years on from devolution, which I think has informed our approach to this. So, and it's obviously timely, post-pandemic, insofar as we are post-pandemic, and it's a question in and of itself, cost of living crisis and so on. I don't want to steal the thunder of the authors of that report, the University of Glasgow, but a few takeaways, and they're known to us, but I think they're worth sort of spelling out. So, life expectancy in Scotland was gradually improving in the first decade of this century. Around a decade ago, improvement stalled, and it started to go into reverse. And the health inequalities gap is growing too, but even more disturbing, I think this is something that Glasgow's report will highlight, and we'll talk about much more over the coming weeks. It's the shape of that gap. So there's evidence that across a whole raft of measures, people in our most deprived communities throughout the life course, the fortunes of those people are not merely worsening, they're becoming increasingly detached from the population at large. And obviously that's storing up very significant problems for the future. Now that's a pretty bleak picture in a sense, but I'm a glass half empty optimist. So I guess what I want to do is kind of emphasise, I think, the opportunity that we have in all of this. When National Records of Scotland a couple of weeks ago published the latest life expectancy figures, which showed, unsurprisingly actually in the wake of the pandemic, a further decline. On that same day, new British Social Attitudes Survey data was published in Scotland, which I think offers us some cause for optimism about the opportunity to take a radical and bold approach. That data showed that 60% of people in Scotland recognise that poverty is a major cause of poor health. 64% think it's unfair that wealthier people can afford better healthcare. Those figures are incidentally higher than England, but I think let's just focus on the opportunity we have here. And as Joe said, a further strand, one of the strands of the review, the work that DFE have been doing on public engagement, fortuitously has focused on attitudes amongst the public. And again, without stealing their thunder when the report comes out, suffice to say that it's pretty clear from the deliberative approach that they've taken that the public's awareness and understanding of health inequalities and what needs to be done in response to the health inequalities gap is significantly improved when people are exposed to knowledge, to expertise, and it shifts people's thinking, and we've got clear evidence now from this group in Scotland, shifts people's thinking from behaviours and lifestyle analysis to one that's much more focused on wider social determinants. As Joe said, we've also been talking to stakeholders across sectors, and I think it's worth mentioning that while we've been undertaking our inquiry review, the Health and Social Care Committee has been undertaking its own inquiry in the Parliament and have recently published their report, and I think there's an opportunity for us to think about how we might respond to that as they approach that work over the second and third years of their work. But I think what all of that means, regardless of how challenging and to some extent bleak the picture is that what we have here actually is really widespread recognition that we have a problem, both within the Parliament and with the Parliament, across institutions, across civil society. That's a pretty good place to start from. We have an understanding of the need variously, and I think there are different kind of priorities and different takes on this, but there's a recognition that we need a coordinated approach, that we need a cross-government approach, we need a whole system approach, we need a long-term approach. As I say, the emphasis on all of those things varies depending on who you're talking to. But we also have an appetite among the public which can lend itself to a bold and radical approach, which we can strengthen if we engage. And I think all of that gives us some cause for optimism that we can turn this around, and there's the basis there of a coalition of the willing, if you like, that can drive that turnaround.
Thank you very much. So I hope you find it really interesting. I've got a few issues I'd like to return to, but then I would encourage everyone to start thinking through any prompts or challenges or considerations if you're able to, then I'll come back in a few minutes to everyone else. So I suppose I'd start with, I've probably got one for each, and that wasn't done intentionally. But Angela, to start with you, you said we need to be joined at the hip, across policy, across portfolios, across government and other partners. Again, you've held a variety of ministerial posts, again, some really important ones for this issue, particularly health or education, your current post, social security. We've got a national mission on poverty. Again, that's absolutely key to tackling an issue like health inequalities. But to what extent do you feel that government has cracked ensuring that those things are very explicitly tied together, as opposed to implicitly tackling an issue like poverty, which can have obviously beneficial impacts on health inequalities? To what extent is that an explicit link, government is absolutely directed towards tackling health inequalities across non-health portfolios? Or to what extent do we need to, really continue to strengthen that understanding and recognition that actually it's not a health issue that can be solved by health alone?
So, in terms of my experience over the years, I think there's a greater recognition that if you want to improve the health of the nation, that not all the answers lie within, our traditional view of what health service is. I do think, as a government, and this is what we're currently working through, particularly with the DFM and his renewed focus on public sector reform and the work that will need to be done in response to the cost of living crisis. So I think we do need to be more explicit with those links. I think government needs to be an absolute exemplar, because you can't go out and preach to the rest of the world. And I do this, about it's not acceptable in the real world for real people to be bounced between complex systems. And we need to be more clearly articulating what person-centred care or wraparound support actually means. Now, in practice, it will mean something different for different people. I know that Marie Todd, in terms of her public health responsibilities, she, as you'd expect, has been at the Health Committee given their health inequalities inquiry, and there was a bit of interest in what they were doing in Wales around very explicit health impact assessments. We do have to, I suppose, watch a wee bit, because we have all sorts of assessments, regulatory assessments in and around any policy or legislation. So you don't necessarily want this proliferation of process that kind of actually at the end of the day just gets in the way of getting the work done. But I think there is something quite interesting in that might help us build on the Fairer Scotland duty, which is in terms of every big strategic decision that you're making, what impact will that have in driving poverty down?
Thank you. And to go from one extreme to the other of kind of talking about the wider non-health, I suppose to bring it back to health is something I'd be keen to explore. I think probably start with Joe, with you, given you've worked, not just with Health Foundation, but equally in the NHS as well, but also Angela would be interested in any thoughts. To what extent is some of this dictated by the fact that secondary care in particular continues to dominate, funding in particular, and actually a lot of the debate around health. So, Scottish Government's got, laudable, arguably, commitments around passing on all health consequentials in full to frontline health services. Quite often that is secondary care. Big, funding commitments in general, which coming out of the pandemic are clearly really important. But is there a risk that secondary care has dominated the debate to the exclusion of wider, not just primary, but then wider health services? Because I suppose if you were to take the consequentials example, it's arguably, if you were to take health consequentials and put them into, for example, tackling homelessness, that arguably has really strong social outcomes, but actually also has really strong health outcomes given the link between homelessness and ill health. So it may be that the system is set up as it should be, but have you got any perspectives on has secondary care dominated potentially to the exclusion of wider non-health issues?
Yes. It's kind of, yeah. I think it does, and but I think there's several reasons for that why it's kind of probably not simple, to change. I mean, one is that, I think as human beings, we have a kind of, we want to know the help is there when we need it. You know, I think there's something, and we want others to have the help there when we need it. So, I mean, you kind of look across all sorts of countries and they will invest a lot more in what's essentially rescue services, saving people, than preventing things in the first place. It's just something built into the human psyche, I think. We all want that. And, you know, people are very, very attached to the NHS, and understandably, because we know it's there for us when we need it. I think one of the problems as well, though, is that because we haven't invested in prevention, and I think because we haven't also curbed some of the factors that drive poor health, whether it's poverty, whether it's our food environment, whether it's, you know, exposure to risk factors like alcohol and tobacco, what we've done is we've just started to store up problems for the future. So I think one of the things I find most concerning when I think about it is that suppose tomorrow, you know, the government says we're going to, you know, get rid of poverty, we're going to make sure everybody has safe, warm housing, everyone's going to have a job, all of that. That would be so brilliant. However, we have still got so much ill health baked into our population that's just going to work through, that we're still going to need the NHS and the services it provides. And this is one of the real challenges of, like, how do you get that balance between the need to address the immediate need now, recognising that isn't going to go away suddenly, it's going to be there, and invest in prevention. And I think it's not easy to see places that are doing this well, but I mean, one place close to home is Wales, where they have started to try and look at their budgets and talk, you know, they have their Future Generations Wellbeing Act. They try and look at, are we doing enough to invest in our future generations as well as meeting the need of the present generation? And then the other country that people talk about a lot, obviously, is New Zealand, where they have their wellbeing budget that talks about the 4 capitals. So they're thinking about how we're investing in future health capital, future environmental capital, economic capital, and the 4th one that I can't remember. But, you know, so I think there are some examples, but this is really the big challenge, isn't it? It's like there's only so much money to go around, you know, and people do want the support now. But I think the other opportunity is this: how do we think of this as a whole society challenge that the whole of society can respond to? And I think, encouragingly, and some of this, you know, I think relates to the pandemic, I think business have started to see that they have a much bigger role to play in people's health and well-being. And for instance, the CBI has a strategy that's sort of about a year in now, but they have actually set, the Confederation of British Industries has set reducing health inequalities as one of their goals. That would have been inconceivable 3 years ago, but there's something that's changed, I think, in the psyche of business. So I think, you know, how employers work, how they ensure that they provide good working conditions, proper rewards, proper job security, all of these things. There's something about, we've got to look beyond government now, we've got to look at business, and we've got to look at communities and the assets within communities and what communities can achieve when they kind of work together on these problems.
And Angela, I'm not expecting you to say we should go raiding Yusuf's budget, but I suppose in drugs policy, potentially that's the intention of, without limitless resources, you know, addressing the immediate impacts versus a sustainable future. So I don't know if you've got anything to add.
So there have been many debates in and around drugs policy about resources that have went specifically into drug and alcohol services in the past and now, and of course we have a £250 additional resource national mission.
Million.
Did I say pound? Oh, million, yeah.
Don't undersell yourself. Don't undersell yourself.
£250 million over the lifetime of this Parliament. But actually, the bigger question is, it's not just. I mean, it is important that every penny of that resource is put to good effect and is effective. But it's also about the resource that lies elsewhere. Task Force had some interesting views about that there should be, you know, ring fencing within other portfolios' budgets. But the point is, you know, if you're investing in housing, if you're investing in mental health, and there's a massive additional resources despite the strained times going into affordable housing, and also to increase, you know, mental health services, you know, the whole expansion of, you know, early years learning, you know. But the question for me is, how does that serve my folk that are the most marginalised, excluded? Are they getting their fair share and their fair access to, you know, statutory services, whether it's healthcare or whether it's housing, and what is it, or transport, what is it that we have to do to ensure that they can access all of these other services that they need and they are entitled to, that they are currently excluded from, either because there's hoops, there's barriers, or stigma. And stigma is probably one of the biggest barriers to treatment, and stigma kills. Because it labels folk, it detaches people further from the rest of society, and makes it much harder for folk to find their way back into the help support that they need.
Thank you.
So I've always got my eye on other folks' money.
Good, it's good to hear. And great, this is a good segue before we throw open to the audience. To come back to your point about there's widespread recognition we have a problem, and I think that's absolutely true, and again, it's one that has existed for decades, if not longer, even before devolution. So I was wondering if you've got any, because again, Bibby, I'm interested in people's views on what we can do, any emerging kind of findings or thoughts from the review. Are we not doing the right things? Are we not doing the right things well enough or at the right scale? Or are we doing the right things but potentially not in the right ways? We know that there's a problem. What is it, do you think, is holding us back from a kind of full policy response that starts to reverse that trend?
No, it's a good question, and it's one of the things I think we're still grappling with actually, is this whole the implementation challenge. So the gap between intention and delivery, or intention and impact on the ground. And certainly, I mean, the health committee's inquiry, which has been looking at this simultaneously, pretty clear that what we need in terms of health inequalities is a more coordinated cross-government approach at the heart of government, and I think we would, the work we've been doing would certainly endorse that. But as Jo has said, this can't just be about government, and it can't just be about national government. And I think it's about thinking about where can delivery be most effective. And there is a concern, rightly or wrongly, amongst many of the stakeholders that we've spoken to, that coordination can sometimes mean centralisation, and that we need, in terms of a government approach, we need a government approach which is about following as well as leading, which is about letting go, as well as holding on, working out where delivery can have the most impact, and thinking about how that partnership with local government, with the third sector, not just in terms of innovation, although that's rightly the case, but in terms of widespread delivery of services, how that can work more effectively. So I think it's a well-trodden phrase, but the whole society, whole system approach to this, and working out what can have the most impact, where is something that we're going to be focusing on in terms of thinking about the implementation gap.
I think that's given everyone, hopefully, lots to think about. Really interesting from my side at least. But plenty from us. We're really interested to hear now any thoughts and comments from all of you here. So does anyone have a question for our panel, a kind of comment or thought on the issue, or what we can do to address it? Don't be shy. Hello.
Okay,
We can take both. Just
Okay.
now and then.
Hi, I'm Dan Aldridge from the Chartered Institute for Information and Digital Technology. So one of the things that we're often talking about is kind of how we mitigate in the future, how we future-proof issues of health inequalities. And one of the things that should be, we think, in the plans for anything to do with health inequalities is baking in credible and well-resourced data and digital strategy that underpins everything, because obviously the data is going to help us transform, target who is going to be at risk, what communities are going to be at risk, and there's lots of tools to our disposal with data. So I'm just wondering if there is a digital aspect to this plan, or a data aspect to this plan, and how Scotland can probably use what is quite a discrete data set and really quite an interesting devolution
so I'm one of the architects of the Wigan deal, which is Joe's very familiar with. I'm a long-standing SNP member, by the way, as well, and Professor of Public Health now at Salford and at Chester Universities, but I'm also co-chairing the Advisory Council for Reform on Reimagining Health, which is Health Angela in its broadest sense, definitely not just health services. And I also co-chaired the Drugs and Alcohol Transformation Board in Greater Manchester in my old life. So just a couple of thoughts from me. Fantastic presentations from all three of you. And obviously we do a lot of describing of the problems of health inequalities, but I think describing the assets is just as important. And often we don't do that second step. So I guess it's a sort of, for Chris and Joe, are we going to look at the assets as well in that whole societal, whole system approach that Angela's describing? And Angela, the greatest assets in Scotland are the people. And actually, I think one of the greatest pieces of legislation that Scottish Government has ever brought in was the Community Empowerment Act. And whether that community empowerment legislation actually has a real role in tackling health inequalities, I would argue it does, because actually that knowledge is power, that skilling up, that building of confidence in all parts of the community is absolutely key. We found certainly over 10 years in Wigan, that certainly did make an impact, and certainly impacted on healthy life expectancy and improved it quite significantly, in fact turned it round. And it's been very much at the heart of the work of community-based drugs and alcohol policy as well, so that some work that Salford's been leading on the communities in charge of alcohol. And maybe we borrowed from Alcohol Focus Scotland, we also borrowed a bit from Glasgow City Council in putting that programme together. But things like that where they're quite cheap to do, but it's actually about building confidence in people themselves. And it does mean challenging professional power, and as Chris said, not being afraid to take risks and letting go.
Thank you very much. Chris, maybe turn to you first on data, because it's not, I don't think it's an issue that is unique to here, that I think right across public policy there's quite often issues of lack of access to timely data, real time, that gives you kind of that good analysis that is then most importantly used for evaluation and figuring out what works and importantly what doesn't work. It'd be good to know if you've got any sense coming through the review of whether or not that is equally an issue here and what we can do about it. And then Angela, I think a really important point around the game, particularly the geographical context of health inequalities, they maybe come to you then on the guys, particularly important around kind of community-led approaches and community empowerment.
Yeah, so it's actually one of the findings of the Glasgow report. Often researchers, and I've been one in my time, will often tell you that what you need is more research, and people who collect data will tell you that what you need is more data. I think we have rich data in Scotland, and we have rich data on health inequalities. But I think, where we're perhaps weaker are on, and I know this from having worked in the learning disability field in particular, are on health inequalities relating to particular protected characteristics. So the ethnicity, individual socioeconomic circumstances, disability are much less routinely measured and collected and visible. Where those kind of axes of inequality are available, they're often reported in isolation based on very small sample sizes, bespoke data sets and so on. So I think there's a real issue there about understanding the complexity that is facing particular communities that we need to get better at monitoring and measuring and making visible in the data that we have.
So I think the point about community empowerment is really important. Areas such as East Ayrshire are actually exemplars in terms of community empowerment and asset transfer. Not every area is, and I agree, whether it's tackling poverty in all its forms, or maybe more specific to need to better support people with alcohol and drug issues, whether it's the recovery community, there is, you know, a huge role for community empowerment. I do think some areas need to make that process a little bit more accessible, easy to understand and navigate. It can feel a bit like, you know, this is your building and actually, you know, we want to flog it so we can flatten it and, you know, sell the land type things, where there's a kind of broader conversation about community wealth and community well-being. Kevin Stewart will be delighted that you think the most significant, or one of the most significant bits of legislation was the Community Empowerment Act. Because as with any, you know, legislation, there's always a debate about, you know, does it go far enough? And the point about assets, I mean, that goes back to all of Harry Burns' work.
It does, yeah.
And one of the things I was very keen on when I came into this post was to have that balance ticket. I needed to give continuity of funding to alcohol and drug partnerships. I do need to follow the money more closely, but that goes to that point about data and visibility and accountability about what's been spent where and when. But I wanted to give those services continuity, but also, you know, we created funds via the Cora Foundation so that the third sector, you know, some other frontline organisations, grassroots organisations, you know, kind of large, small organisations actually could just apply directly for funding. Because I think there's a bit, in some areas of the country, people say, you know, well, we can't get access to that funding, you know, so we needed to just try and create a bit more of a level playing field, and that's very much, you know, recognising, you know, the role of community-led organisations, the role of lived experience led organisations, that actually people within themselves have the solutions, and, you know, it's not me, the forward social worker, coming and, you know, kind of doing an assessment and, you know, coming up with an action plan and sorting everybody out. I think in terms of digital strategies, I'm not probably going to answer this point in the way that you meant it, Dan, but there is a much bigger role for improving digital access amongst people with problems with addiction. We took a bit of a pasting, and I can't remember whether it's the Daily Express or whatever. I knew it would come. I don't care, right? The Simon community in Glasgow ran this amazing project with some funding from SG that was providing people with drug and alcohol problems access to phones, because a lot of folk that don't have access to phones and, you know, kind of packages and apps, and there was, and of course the stereotype is, well, folk will just take that to cash converters, but the reality is what they could do with that equipment and being upskilled was far greater than the £20 you could get from cash converters. And there's very, very few people, you know, that didn't hang on to that equipment. And I suppose that's what I mean by stigma. They'd be like, oh no, you can't give, you know, bits of, you know, expensive equipment. Well, actually you can, because the Simon community showed that you can work with people, upskill them, and, you know, and how that improved their, you know, quality of life, and, you know, began that journey about, you know, access to, you know, education as well as information about where to get help when you were, you know, in crisis or whatever. And I do think the point about data is important, because I'm accountable to Parliament. This goes a bit about coordination or control. I'm accountable to Parliament, right? No ifs and buts. So I need to know where the money's going. And it's, you know, and if I'm, you know, allocating money to, for example, improve access to residential rehab, well, I do need to know if that's where it's going, or whether our, you know, chief finance officer sitting on it somewhere else to, you know, use it for other purposes, because that's, you know, I'm going to, you know, make sure that doesn't happen. So, you know, data is important, but I do share that frustration that, you know, and it's a kind of perennial discussion with my poor civil servants and politicians, like, we'll have a rapid review of benzodiazepine use, you know, or mental health, or, you know, the implication of methadone and drug deaths or whatever, and invariably you get something that, you know, kind of begs more questions than answers. But I mean, it just plays to, I suppose, what we know, that there isn't one solution, but there's many, and we need to be, you know, working our way through that complexity as best we can.
Do you want any comments from your side on this? It's fine. I want to put you on the spot, sorry. I think we've got time for any kind of final rapid fire questions or kind of quick fire or any burning thoughts from anyone before we have to wrap up. That's right. It's been so illuminating that there are no questions because we either have now or the Health Foundation's review will provide all of the answers that then governments can go in and fix it all. So that's perfect. Yeah, I was going to ask one final point.
Well, others might want to as well. I suppose it's about the long-termness of all of this, really. I mean, you talked about the it's both a sprint and a marathon, and I get that. It's very clear that our approach needs to be long-term, and therefore I think this was a real challenge that we tried to address when I was at the Scottish Commission for Learning Disabilities. If you're thinking in the long term, if you're thinking, what do you want the lives of people with learning disabilities? And here you've got a huge gap in life expectancy, so it's very relevant to this question. What do you want those lives to look like in 50 years? Because it's generational change that you're talking about. What can we do over the next 3 or 4 or 5 years that is foundational in terms of achieving change over the longer term? So short term is fine. To a point. I mean, many of our stakeholders, that we spoke to inevitably talked about issues with short-term funding and short-term investment as a perennial problem. You've heard that many times. I think the question is also about what should and can we be doing in the short term that actually has a beneficial impact in the longer term. It's about thinking ahead. So the long term in all of this is really important because there isn't an overnight fix any more than there's any one fix.
Sure, any final comments from you?
Yeah, I definitely agree with that, and I think the second thing I'd add is just we need to have a better way of understanding the different experiences people have. I've been really struck with the sort of debate that's gone on around inflation recently, where people said, there's no point talking about a headline figure of inflation of 6% or 7% because for some people on some budgets, given the things that they're buying, they're actually facing a 20% inflation. Yeah. And that's kind of what's happening with health inequalities, I think. That within the population, some people's experiences are so materially different than others that their health is being eroded at a much faster rate than other people's. And we just don't really have a way, and maybe this is where the data can come in, but we just don't have a way at the moment of really understanding that, I think, in real time. And maybe that's the kind of thing, if we have a bit more insight into that, we might see this is more of an emergency than we've kind of really recognised.
Thank you. And Angela, any final comments?
No.
All right then.
Thank you.
Thank you.
Could I, quickly ask something? Yes. How easy is it for different groups to actually work in networks so there aren't duplications, things like that? I'm just saying this from experience. A few years ago, 7 women either had cancer, living with it, got together because we'd seen some things and we'd heard some things about maybe someone not going for treatment because you've got £5. What do? Feed your family, use it for bus fares, it's fine. Claiming things afterwards, but if you don't have it in the first place. So we got together, we thought about it. So we've got free bus tickets for people for going for cancer treatment, and you can take someone with them, which is even a bigger bonus. A couple of bus companies have actually bought into this. But the one thing that we were talking about was lived experience, as I say, because we've all the trustees of cancer or have had it, and we set up network meetings just in Dundee. It's a small thing, but we've set up network meetings between the cancer charities in Dundee, Macmillan and Maggie's and Tayside Cancer Support and all other charities within Dundee. We have network meetings about 4 times a year so that we're not duplicating stuff that's going, but we also hear what other charities are doing, so we can actually work together, and it's a broader scope that we're covering. So it's just that charities, if you have ideas for any groups, it's going to be very precious and people hold on to it, but sharing it out, we've had a couple of ideas nicked, but that's okay, it's working. But doing that, but how easy is it to get groups to work together and be open enough to say, well, we're doing this or we're doing that, and so that there aren't things duplicated.
So you didn't want the final word, Angela,
So,
but I might give this to you.
sorry. So speaking about my own constituency, I certainly see far more evidence of, and I'm thinking about third sector organisations working very collaboratively together. Yesterday morning I visited the food bank distribution centre in West Lothian, and they were talking about all the connections that they were making with debt advisory services, for example. The work they were doing, whether it was with churches in terms of use of their facilities, so you could really see that and feel that at a very practical level. I do think in terms of how organisations are funded, I think we need to learn to fund in a way that encourages collaboration as opposed to sharp elbows. So I think we could improve that a bit. Again, I do see in some areas the third sector interfaces really kind of bringing together and being that focal point for tapping into volunteering type services. And again, there are various, I suppose, forums within governments. We've started to kind of bring alcohol and drug partnerships together, like the cities. So although the latest figures show that for the first time we didn't have an increase in drugs death, every city bar Dundee had an increase in drug deaths, although Dundee still has the highest rate of drug deaths. So we bring the cities together, and I think what we need to do more of is bring the kind of statutory services, in particular NHS, together with the third sector. I'm very interested in who can prescribe and where, and I think that model of quite centralised NHS addiction, doctor knows best type stuff doesn't work, and actually we need services that absolutely have the appropriate clinical input, not arguing against that, but they are much more multidisciplinary. You can see attempts in that with primary care, but actually we need those services within communities, so that people aren't tripping up to a kind of quite centralised large hospital to access treatment, that they can go to a third sector who have appropriately qualified prescribers. So I think it's a really good point, and yeah, it's like everything else, we're on a journey.
Yes.
Yeah.
Yeah, I think one of the big things is a lot of the time not answering questions, but actually how do you get it out there that people know the questions to ask in the first place?
Chris, you want a very quick?
It's very quick. I just to say, I think it goes all the way down to the level of the individual and the wraparound for individuals. My husband works on the front line of social care with people with learning disabilities and autism. So this is a sort of daily conversation in our house, and even amongst people who are receiving support from a number of quarters, the coordination of that support. Obviously self-directed support. Ultimately, the important thing is that the individual is directing that support. But I think we can be much smarter about that, and we can enable people on the front line, whether they're in the third sector or the statutory sector, using the statutory sector, to be much smarter about that and use money more efficiently.
Thank you.
Thank you. Yeah, so a huge thank you to all of our speakers. I think that's been a really fascinating conversation. I think we'll all look forward to the Health Foundation's various reports coming out from review, and hopefully seeing lots of further action being taken forward. Angela, thank you very much for your time. As always, a premium at these events, conferences, so really appreciate you coming today. And again, a huge thanks to the Health Foundation for supporting the event, and a huge thanks to all of you for coming out.
Thank you.